Welcome to MLT 101. My name is H1 Barnes, and today we'll be going over the phlebotomy procedure. We'll be starting with terminology, and then I'll be going over the steps in the phlebotomy procedure when using the evacuated tube system. To start with, an accession, or to accession something, is the process of recording in the order received. When you accession a sample that's been received in the laboratory, you are documenting that that sample has been received and then preparing it to go to the next location to actually be tested. Anchor, which means to secure firmly, as in holding a vein in place by pulling the skin taut with the thumb. ASAP stands for as soon as possible. Oftentimes this means within 2 hours. If a test is ordered ASAP, most labs will require that the test be performed and with the results sent to the physician in under 2 hours. Bedside manner, the behavior of your healthcare provider toward, or, and here's the big part, as perceived by the patient. Hypothetically, you could have a medical provider who is very rude, but if it is positively perceived by the patient, that would be considered good bedside manner. On the reverse, you could have a physician who is incredibly polite, but if it is perceived negatively by the patient, it would be perceived as poor bedside manner. It mostly comes down to having good social skills and connecting with the people that you are taking care of. Fasting is to not have any food or drink except water. Oftentimes, an exception will be made for tea or coffee, so long as no additives such as sugar or cream are introduced. Hospice is the term for caring for patients who are terminally ill. Needle phobia, an intense fear of needles. This is something that is unsurprisingly common. Needle sheath, the needle cap or cover of the needle. Palpate, which is to examine something by feeling it or touching it. Patency is the state of being freely open, as in the normal condition of a vein. To requisition is the form on which a test is ordered and entered and sent to the laboratory. Our procedures for phlebotomy, now keep in mind, every facility you work at is going to have a slightly different variation of the phlebotomy procedures. This is just an example set of steps that can be used to perform phlebotomy. There are a few critical steps that are required by CLSI, the Clinical Laboratory Standards Institute, that you just have to do no matter what. But other than those specific required processes, pretty much everything is going to be custom tailored to the actual facility you work at. Your first step is going to be review and accessioning your test request. Legally, a blood collection procedure is going to start with the test request from a physician or other qualified healthcare provider, such as a physician's assistant or a nurse practitioner. Accessioning your test request is the process of recording that request in the order you receive it. When your test request is accessioned, it's assigned a unique number, which identifies the specimen, and all further work and documentation that is done with that specimen to connect it to the person, to the patient that you are taking care of. This is going to ensure that the right person gets the right work done and the right data is sent for the right patient to the physician. Keep in mind, if you're doing routine work and a stat test request comes in, short turnaround time, that's going to take priority above everything else. You're going to pause what you're doing, and you're then going to handle that stat work instead. Oftentimes that might be due to an emergency, or that might be due to a specific timeline that has to be maintained. Like if a patient is about to go in for surgery and they're going to put someone under general anesthesia, they may need certain tests to be performed to ensure that that's safe for the patient. And that has to be done right away because there's a whole surgical team waiting on that person's results before they can do any work. Step 2 is going to be to approach, identify, and prepare your patient. If it's an inpatient environment, and that means somebody who's staying overnight in the hospital, they'll usually have their own room. The things you're going to look for are signs on the door or in the room for information concerning which patient is in the room. Of particular importance are signs that may indicate certain infection control precautions, such as droplet or airborne or contact precautions, or if that person has a latex allergy. Now, any modern facility is going to eliminate the use of latex in the facility. In an ideal scenario, latex will not be a concern because it will not be something that your facility even has. However, if you're working in an outdated facility, it may still be a concern. When you enter the room, if a physician or member of the clergy is with your patient, don't interrupt. Just patiently wait. Give them some privacy, step back, wait outside the room until they're done. If the draw is not a stat, timed, or other urgent priority request, go take care of one of your other patients and check back when you're done. If it's stat, timed, or urgent and needs to be done now, introduce yourself into the room, explain why you're there, and ask permission to get that work done in a polite manner. When you approach your patient, you're going to identify yourself to your patient, tell them your name, your job title, and what you're there for. An example would be, good morning. My name is HM1 Barnes. I'm from the lab and I'm here to collect your blood, if that's okay with you. You are always going to ask permission to collect somebody's blood sample. You are not just going to stab somebody because that is assault. If you stab somebody without their permission, that is assault. And that is illegal. Do not do that. You must obtain consent. You must obtain consent before any venipuncture practice. It doesn't always have to be stated verbally, though. Someone could nod their head or extend their arm or something to indicate consent. It does not necessarily have to be, yes, you may draw my blood. You must never collect a blood specimen if someone indicates they are unwilling. You just don't do it. It doesn't matter how much the physician says they need it. If your patient says no, that's a no. If your patient objects, you're going to document that and you're going to report that to your supervisory staff and to the physician that was ordering the request. After you've approached the patient and identified yourself, then you're going to identify your patient. You're going to verify your patient's identity. Usually you're going to use the name, date of birth, and in the military, we use a number called the DOD identification number. You want to avoid using social security numbers if possible. Use something that can't be used for somebody's identity to get stolen. You want to prevent the use of those kind of identifiers. So use things like a name, date of birth, and DOD ID or a unique hospital identification number. Have the patient tell you their name and date of birth and ID number, and have them spell their last name. Don't walk in, tell them all the information, and ask if it matches who they are, because if your patient is incoherent, or they're not sure what's going on, or they got hit in the head, they may just nod along and say yes, thinking that that's what they're supposed to do. And you could end up drawing the wrong person's blood. Make sure to positively identify that patient. Have them tell you their information. In addition to that, an inpatient is normally going to be required to wear an ID band, usually on one of the wrists, which is also going to have their information, and you're also going to check that as well. It's called a three-way ID. You make a verbal statement, you check the ID band, and a visual comparison of the labeled specimen to the ID band. Never ID a patient from a band that's not attached to them. And if the patient is not wearing an ID band, it is usually acceptable to ask the patient's nurse to attach the ID band. Don't attach it yourself. Ask their nurse or clinical team to do that. They're the ones that are working with that patient who can for sure know that that person is who they think they are. Proper ID and informed consent cannot occur if your patient's asleep. If they're sleeping, gently wake them up and wait for them to be coherent enough to actually provide consent. For an unconscious person, ask a relative or a nurse to ID the patient and record their name. Talk to the unconscious person as you would if they were alert, as some people can hear you even though they're unresponsive. I myself have encountered situations where I have had patients who could hear me and they were aware of what was going on around them, but the most they could do to respond was wiggle a finger slightly, and I had to pay attention for that. There are cases where that kind of thing can happen. So if you don't talk to the person and communicate with them, and they just suddenly feel pain in their arm from a needle, you could terrify that person. You don't want to do that. For an outpatient is typically going to be called into your phlebotomy area from the waiting room. Usually, for routine work, they're going to be called in on the order of arrival. Whoever checks in first gets seen first. That's standard practice. An outpatient is not usually going to have an ID band, but you still have to identify that person. You have to identify that person. The receptionist have likely to have already identified them when they checked in. Doesn't matter. You're going to ID them again. Always ask that person to state their name and date of birth. Have them spell their last name, because there are names that can sound the same with different spelling. Often people will be required to physically show an identification card like a driver's license, a common access card, or a clinic issued identification card. You have to make sure that that card they show you, if your facility requires the physical showing of an ID card, matches the test requisition that you have. After you've identified your patient, you're going to verify any dietary restrictions and allergy sensitivities that they have. If the test requires any dietary instructions, such as a fasting test, they're usually going to be fasting overnight. They'll come in the morning, and then they're going to go get breakfast after they see you and get their blood drawn. Typical fasting time is going to be 8 to 12 hours. And your patient can have water and unsweetened tea or coffee that has no creamer in. Usually those will be allowed by your facility. It is good to remind people, if they're coming in, that they can drink water if they're fasting, because you don't want someone who is sick already to go 12 hours without drinking any water. That's not good. If your patient does not fast or follow their dietary restrictions, let their physician know or their nurse know. Frequently, your facility will just have a policy in place that says if the patient's not fasting, have them come back and try again another day. Because there are tests that just can't be properly done if your patient's not fasting. You're not going to be able to do a timed glucose tolerance test. You're likely not going to be able to do a proper cholesterol test or a blood sugar test, just to name a few of the immediate ones that come to mind. After you've verified any dietary restrictions, you're also going to verify allergies. If you might have to use iodine, you got to make sure that your patient's not allergic to shellfish. If your facility uses latex, you have to ask if they're allergic to latex. If your facility doesn't have any latex use, you still need to ask if your patient has any allergies which may be of concern. Once you've done that, you're going to sanitize your hands and then put on your gloves. You'll position your patient, apply your tourniquet, and ask a patient to make a fist. Now, putting on gloves before you palpate to feel a vein is going to depend on your facility. Some facilities will require that you put on gloves before you make any physical contact with a patient, no matter what. Other facilities will require that you put on gloves only when there's a risk of exposure to blood, body fluids, or moist locations on the body. It is easier to find a vein if you are not wearing gloves, especially for people that are new to this skill set. So as you position your patient, apply tourniquet, and ask them to make a fist. The process for this, if they're an outpatient, they're usually going to be sitting down in a chair. If they're an inpatient, frequently they'll be laying down in a bed already, so they are already positioned. If you're using a phlebotomy chair, what you want to do is you have the patient sit down. You'll adjust the arm on the phlebotomy chair so that they can lay their arm out comfortably on that armrest. It shouldn't be so low that their arm is at an odd angle. It shouldn't be so high up that their arm is sticking straight out in front of them. You want their arm to come down with their elbow at a slight angle. That way you have room, if you need to have them prop their other hand balled up into a fist underneath their elbow to flex out that elbow a little bit, because that can be a position you put someone's arm in to help find veins. You don't always need to do that. Most of the time you won't, but it is an option that can help you find a vein. Ask your patient if they have a history of fainting. If this person has a history of passing out when their blood gets drawn, you don't want to put them in a regular phlebotomy chair, because once you put the needle in their arm and the blood starts to flow, they're likely to pass out on you. A lot of people, when they pass out, are going to have one of three reactions. They're either going to go completely limp, they're going to stiffen up like a board, or they're going to start to spasm and shake. Those are the three common reactions that I've seen patients undergo during phlebotomy. Most of the time, patients go limp. If that happens, it is now on you to make sure that that person does not fall out of the chair or hit their head on the way down, if they're so big that you can't hold them in the chair, let's say you're 120 pounds, your patient's 400 pounds, good luck holding that person up. You will then, as gently as you can, guide them down so that they don't hit their head on anything and injure themselves. That being said, the key concern here is to get the needle out of their arm as quickly and safely as possible if they pass out, because if they start spasming on you, or if their body weight carries them down onto the needle and pulls that needle deep into their arm, that can injure them. That can cause a serious injury, and you want to avoid that. If your patient stiffens up like a board, they're likely that they're just going to stay in place, and all you got to do is get the needle out of their arm, and then just make sure, stand next to them, stand in front of them, make sure that they don't go limp and fall out of the chair. Wait for them to wake up. Some places will have smelling salts for you to waft under the patient's nose. That's a respiratory stimulant. Other places will have you use a cold pack on their forehead or the back of the neck. Oftentimes, as your patient starts to come back to, you'll see them have the color return to their face, and they'll break a sweat on their forehead. Once their breathing returns to normal and you see sweat beads start coming on their forehead, expect that that person is going to regain their coherence and ability to communicate with you effectively again. Now, occasionally, people will undergo convulsive syncope. It's not common like the other two are, but every now and then, if somebody passes out because they get their blood drawn, they will start to shake and it will have the appearance of a seizure. If this happens, again, make sure that your patient doesn't injure themselves. Make sure that you get the needle out of their arm as quickly as possible. It is imperative that you get the needle away from the person who is convulsing. In all circumstances, if one of your patients passes out, call for assistance. Do not quietly stand there dealing with it by yourself. Call for another team member to assist you. For venipuncture in the antecubital area, the AC area, you want to extend your patient's arm downward in a straight or slightly bent line from the elbow. This position is going to help fix the veins so that they're less likely to roll, and it's going to make them pop up against the skin. You have the arm down because gravity is going to cause blood to stay down in the arm, and gravity will assist you. It'll help the veins be more prominent. In addition, having it in a downwards position is going to ensure that your blood collection tube is going to fill from the bottom up when you're holding it in position in their arm. It's going to prevent a reflux or backflow of the tube's contents back into the person's vein, and it will help reduce the chance of an additive carryover from one tube to the next. You want to apply your tourniquet 2 to 3 inches above that person's vein. Depending on the source material you read, you may see 2 to 4 inches, you may see 2 to 3 inches, you may see 3 to 4 inches. Every reference you check is going to say a slightly different distance. The key thing here is that you have it at a distance that's not so close it gets in the way, and not so far away from the intended phlebotomy site that it doesn't provide you with the assistance that you need. About 2 to 3, 3 to 4 inches above the target site is going to be sufficient so that you have the room you need to work. And when that tourniquet restricts venous return blood flow, it creates a high pressure area in the AC area that you're planning to draw blood from. That's the goal with this. For most people, you can look at the target site. You can just lay your palm flat down right above where that target site is. Put your pinky on top of where you're planning to poke with a needle and draw blood from. And then just wherever the top side of your pointer finger is, that's an appropriate place to line up the tourniquet. That'll usually work. It's just a quick and dirty technique to find a place to put it. When you put your tourniquet on your patient, you want it tight enough to slow the venous blood flow, but not so tight that it cuts off arterial blood flow. If it's so tight it cuts off arterial blood flow, you're defeating the purpose and you're not going to get any blood. If you don't put your tourniquet on tight enough to slow or restrict the venous blood flow, the tourniquet's not going to do its job and it's pointless to have on there. It's completely useless. If you have a patient who is more heavy set and they've got a lot of subcutaneous fat, oftentimes the tourniquet will start to dig into the fat and the loose skin, and it'll become very uncomfortable. It won't sit flat and wide on the arm. It'll ball up into a tight little line, almost like you were trying to strangle somebody's arm with a shoelace, and it's going to be really uncomfortable for your patient. Something you can do to help with that is if they have long sleeves on their shirt or you have some type of cloth or something nearby, is that you can place that over where the tourniquet's going to go, and then you put the tourniquet on top of that sleeve or on top of that piece of fabric so that it doesn't dig into your patient's arm. That'll make it more comfortable for them without interfering with the effectiveness of the tourniquet. Once you have your tourniquet on, you're going to select the vein. Then you're going to release your tourniquet and ask your patient to open your fist. Your preferred site is going to be the AC in the arm. That's usually where you're going to find something. And your patterns are typically going to be the H or M pattern. Not always, but they are common patterns. And what I mean by an H or an M is when you look at somebody's AC area, you'll see a vein on the left side, a vein on the right side going up that elbow area, and then there will be a vein that crosses from the left to the right. That's our H pattern. Our M pattern is when that crossing vein, instead of being horizontal, is diagonal. The median cubital and median veins are usually our first choice because they're typically pretty close to the surface. They're not likely to roll around, and as long as you anchor them properly, you should be able to keep them consistently in one place. They're also fairly far away from the nerves that you want to avoid hitting. The cephalic and median cephalic veins are going to be your next choice. Your basilic and median basilic are your last choice because they are near where the median nerve and brachial artery are. And if you're not careful or inexperienced, you could end up puncturing the artery instead, or even worse, the nerve. If you puncture the artery, they're liable to just have a nasty bruise later. You can patch that up the same way you would a vein with gauze and a wrap, and it's going to cease the blood flow because it's a tiny hole from the needle. It's not like somebody lost their hand and blood spurting everywhere. But if you hit a nerve, that nerve's not going to heal. When selecting a site, you want to avoid drawing from a burn, a scar, or a tattoo. You want to avoid drawing blood from a damaged vein or a hardened vein or a clotted vein. You also want to avoid drawing from a valve in a vein. Oftentimes, if you find a person's vein, you can trace that vein up and down their arm, and you might find what feels like a little bulge in that vein, or like there's a ball in the vein. That's usually an indicator that there is a valve there, one of the valves that prevents backflow in the venous blood system. You don't want to draw blood from that valve spot with the needle because, one, you don't want to damage the valve, and two, even if you successfully avoid damaging the valve will often get in the way of the blood flowing properly while you're trying to draw blood, and it can prevent your phlebotomy from being successful, and then you'll have to stick them again. You want to avoid anywhere that's swelling or has a visible hematoma, which is a bruise, or at the same side where somebody has had a mastectomy. And for those who aren't familiar with the term, that's something that'll often be performed for breast cancer patients where one of the breasts is removed. If somebody has had a mastectomy, draw blood from the other side that has not had a mastectomy performed. If your patient has had a double mastectomy, consult with the physician to see how they would like you to continue on. Also avoid drawing from a paralyzed arm. Something to keep in mind is it's not that you can't draw blood from a tattoo. It's that for the newbies that are relying on the visual indicators that there's a vein there, one, tattoos are going to conceal it and raise the difficulty of performing the procedure. And two, if you put a scar tissue spot in the middle of somebody's artwork, that's really rude. Most of the time, your patients are going to have the prominent veins that you're looking for in their dominant arm. So if you want an easy way to go about this when you're learning the procedure, just draw blood from their dominant arm. Once you get better at it, I personally prefer to draw blood from someone's non-dominant arm so it is less inconvenient for that person. Once you've found a vein, roll your finger from side to side, from one side to the other, and that's going to help you determine the boundaries of that vein. Once you've selected your site, release the tourniquet. At this point, you're going to clean and air dry the site with an antiseptic. You do not want to introduce microorganisms from the skin into the vein, and you do not want to introduce microorganisms from the skin into the blood that you are drawing. The standard antiseptic we're going to use is 70% isopropyl alcohol. Usually they're just referred to as an alcohol pad. If you just say, pass me an alcohol pad, every phlebotomist in the country is going to know what you mean. You're going to use friction to clean an area 2 to 3 inches in diameter around the selected site of needle entry. When you do this, you're going to put the alcohol pad down directly on top of the location you intend to draw blood from, and then using pressure, you're going to wipe that wipe in a concentric spiral-like circle, starting from inward, going outward in the shape of a cinnamon roll, to physically scrub and pull away any bacteria or contaminants that are in that part of the skin. Now, depending on where you're working, and this is especially prevalent in a deployed environment where people may not get to shower every day, you might have to clean somebody's arm twice. If you pull that alcohol pad away and their arm changed color because you just scrubbed grease or dirt off of somebody's body, grab another alcohol pad and clean it again. Check the alcohol pad and make sure that the alcohol pad didn't pick up a bunch more grease or dirt. You're going to continue that until your alcohol pad comes away clean, and now you know you have a clean site to draw somebody's blood for. Usually that's not going to be an issue when you're working in a clinic or a hospital, but in a deployed environment, not everyone has the chance to shower every single day. And you may have people that are coming back from the field or people that are working in heavy-duty engineering environments who are working in mud and blood and grease and dirt for days straight at a time. And you've got to account for that. After you've cleaned the site, we're now going to prepare our equipment. We clean the site before we prepare our equipment to give the alcohol time to dry on the person's arm. One of the number one causes of pain from this procedure is somebody being too hasty and not waiting for the alcohol to dry. If you push a needle through wet alcohol on somebody's arm into their vein, you have just pushed isopropyl alcohol into somebody's skin and into their vein, and it's going to sting. It's going to hurt, and it's going to amplify the pain caused by the procedure. If you wait for that rubbing alcohol to dry first, it's going to significantly decrease the amount of pain and discomfort your patient will go through. It can actually be a relatively painless procedure, where at most somebody feels a sensation of pressure if it is performed very well. To prepare your equipment, you're going to select the tubes based on the tests that have been ordered. Then you are going to grab your needle and your hub. You're going to select and attach the needle to your collection device, but you're not going to remove the needle sheath at this point in time. Once you've gathered all that equipment, you've gotten your gauze pad ready, you've gotten your self-adhesive wrap ready. And when I say get your gauze pad ready, if you have gauze that's already open in a big, large bulk container of gauze, just grab one, set it where you can reach it with one hand, and you're good to go. If you have individually wrapped sterile gauze, take your gauze, open it, set your sterile wrapping down, and then place the clean gauze on top of that sterile wrapping. You don't have to do sterile technique for this because this is not a sterile procedure. It is a clean procedure. Once you've prepared all of your equipment, you're going to put on your gloves, if you have not already put on gloves. You want all of your equipment within arm's reach on the same side of your free hand when you're doing venipuncture. If you're going to hold the needle with your right hand, you want to position all of your equipment so that you can easily reach it with your free left hand. If you're going to draw somebody's blood and hold the needle with your left hand, position all of your equipment so you can reach it with your right hand. You should never have to reach over yourself or over your patient to grab your equipment. It should be freely available for your open hand to reach and access so that you don't have to risk wiggling the needle around in somebody's arm while you're trying to maneuver to grab your stuff. Next, you're going to reapply your tourniquet. Once you've done that, you're going to uncap and inspect your needle. Once you've visually inspected the needle, if the needle is acceptable, you can use it. If not, say there's a barb or there's a roughness or a dullness or some type of imperfection to the needle, you're just going to dispose of it and get a new needle. End of story. You're not going to walk up to somebody and be like, hey, do you think this needle's good? If you have to ask, just toss the needle and get a new one. Put it in the sharps bin, get a new needle. There are a few tests, such as lactic acid, that you may have to collect without using a tourniquet, but most of the time you're going to use a tourniquet for this. Ask your patient to make a fist. You're then going to use your free hand, the one that's not holding the needle, to anchor the vein. So you're going to place your thumb about 1 to 2 inches below the site you plan on inserting the needle into, and slightly to the side. When you do this, make sure that you don't press your thumb onto the vein that you intend to draw from, because if you're upstream in that blood flow, I say upstream, if you're pressing down upstream of where you plan to draw blood from, you're going to block off the flow of blood to the needle. And even if you get the needle in the vein, you're going to think you didn't because you're blocking the flow of blood. To anchor a hand vein, use your free hand to hold your patient's hand just below the knuckle, and use your thumb to pull the skin down taut over the knuckles while you bend the patient's fingers. Or you can have your patient make a tight fist. When you're getting ready to insert the needle, you want the beveled edge. That means if I look at the pointy tip of the needle, the beveled edge is the side the opening of that needle is facing towards. I should be able to hold the needle up, look at it, and the open side of the inside of that needle lumen should face me. Position your needle so it's lined up above the vein and following the path of the vein. Let your patient know that you're about to start the blood collection. Some people will want you to do a countdown, 1, 2, 3. Some people may not want you to do a countdown. In my personal experience, I found that I have less satisfied patients when I do a countdown prior to drawing their blood, because I am mentally priming them to think that they are about to experience pain on a set interval, and then their expectations are filled and they experience pain when they get their blood drawn as the time hits 3. So instead of doing that, I just say, are you ready for me to draw your blood? And as soon as they say yes, I'm just going to go ahead and draw their blood. That way they don't have time to mentally prime themselves to anticipate and expect pain. If they don't mentally do that and psych themselves up for it, they're going to feel less pain. Insert the needle into the skin at an angle between 15 to 30 degrees. A shallow vein, you're going to use a lower angle, closer to 15 degrees. A deeper vein, you're going to need a higher angle so you can get deeper in the arm, and that might require 30 degrees. If you're using a butterfly needle on a very shallow vein, like a hand vein, you may have to insert the needle at 10 degrees or sometimes even less. Oftentimes when drawing blood from a hand vein, once you penetrate the vein, you'll penetrate the vein at a higher angle, perhaps 15 to 20 degrees, insert that needle ever so slightly into the vein, and then you're going to drop the angle on the needle down so that the wings of the butterfly needle are flush with the patient's skin, and you'll ever so slightly and gently thread the needle deeper into the vein, advancing it forward into the vein, so that it can secure itself safely inside that person's vein. You're going to do this in one smooth, steady forward motion. If you poke, stop, poke, stop, poke, stop, poke, stop, finish, it's going to hurt that person. If you're using a large needle and you don't do it in one smooth motion, then you run the risk of having the pointy beveled edge of the needle penetrate into the vein without the full interior diameter, that lumen of the vein, being sealed off underneath the person's skin by the time the blood flow starts. If that happens, blood will travel up through the open lumen of the needle, and instead of going into your tube, it will squirt out the gap between the patient's skin and the open lumen of the needle, and it will fountain into the air. It will literally make a blood fountain into the air. So you have to do this in one smooth motion. Once your needle enters the vein, you're going to feel a slight give or a decrease in resistance. When that happens, stop advancing your needle. Securely anchor your tube holder or syringe by pressing the back of your fingers or knuckles against the patient's arm, and let go of your anchoring that you're doing with your other hand, the hand that's not holding that needle. To see blood flow, if you're using the evacuated tube system with a straight needle, you have to put a collection tube onto the tube holder until the stopper on the tube is completely penetrated by the needle in the hub. Once you do that, you will then see blood flow. If you're using a syringe or a butterfly needle system, you'll see what's called flash, which is where a small amount of blood will flow into a chamber that's in the syringe or the butterfly needle to indicate to you that you have successfully punctured and entered that vein. Blood flow into a syringe is achieved by slowly pulling back on the plunger with your free hand. Once you've established blood flow, and you want to do this in 60 seconds or less, you will release the tourniquet and ask the patient to release their fist. As soon as you see blood flowing freely into your first tube, or it's flowing into the syringe, or you get flash on that butterfly needle. Blood should continue to flow until you've filled up multiple tubes or that syringe has been filled. You do not want to leave the tourniquet on for more than 1 minute. It can cause an effect called hemoconcentration, which can interfere with your test results and invalidate them, meaning that you would have to draw that person's blood again and explain to the patient that you did it wrong and it's your fault they're getting stabbed with a needle twice. Following the order of draw, you're going to place your evacuated tube system tubes in the holder, advance them onto the needle. You don't want to pull up, press down, or move the needle back and forth or sideways, because if you swing that sharp, pointy edge of the needle inside somebody's vein, it can hit the other walls of the vein and puncture out the side of the vein or the back of the vein and lacerate it. This can actually cause somebody's vein to effectively rupture underneath the skin, and you'll see a sudden swelling up to the size of a golf ball. If that happens, you're going to immediately withdraw the needle from their arm, and you are going to use a gauze and self-adhesive wrap to apply pressure to the location. If you need to continue drawing their blood, you are going to use the other arm. When you're drawing blood, keep your patient's arm in a downward position to help maintain the blood flow. Your evacuated tube system tubes, your vacuum tubes, also known as vacutainer tubes, are going to fill until the vacuum is exhausted. They've got a set amount of vacuum pressure inside that's going to fill them to a set level. When they stop filling, they're good, they're done. Take your tube off, mix it, gentle inversion to mix it, and put your next tube on and collect that tube. When you're preparing to discontinue collecting blood, fold a clean gauze square into fourths and place it directly and gently over the site where the needle enters the skin. You are not going to apply pressure while the needle is still in the patient's arm. Once you remove the needle, you're going to do two things at the same time. Once that needle is out of the person's arm, you're going to apply pressure with your finger onto that clean gauze square, and you're going to activate the safety feature on the needle. Once the safety feature on the needle has been activated, you're going to ask your patient to hold pressure on that gauze square so that you can go reach your sharp spin and dispose of the used needle. When you have an open sharp, such as a needle, managing that safely is going to be your highest priority. OSHA regulations prohibit recapping blood collection needles after use. This is specific to phlebotomy. If you're in an operating room or some other medical environment, you may see medical staff recapping a needle. Different medical professions have different specialty standards. Don't sit there and go off on somebody because you saw them recap a needle. Their profession may train them to do that. We all have our own professional methods for doing this. Ours is to not recap a needle. Another specialties may be different. Apply pressure to the site for 3 to 5 minutes or until the bleeding stops. It is common to have your patient hold pressure while you label the tubes in front of them. I personally prefer that method because once I wrap somebody's arm up, they often take that as an indication that they're done and it's time for them to go. So they're going to lift the arm up on the chair, they're going to stand up, and they're going to start walking out and be on their way. You have to label your tubes in front of the patient. The person whose blood you draw has to see you label those tubes. So if you have them as part of the team holding pressure on that phlebotomy site while you label the tubes, they will patiently wait for you to label the tubes. You're not going to ask your patient to bend their arm, because if you do that, you could interfere with the formation of a clot. It is, however, useful for them to keep their arm extended or even raised. Either of those can be of assistance if the bleeding doesn't want to stop. Now, 3 to 5 minutes will stop visible bleeding that is outside the surface of the skin. Something to keep in mind is you put a hole in somebody's blood vessel, it's going to try and bleed. It is fluid trying to escape a system from high pressure to move to a system in low pressure. The natural tendency is for that fluid to try and escape. If they take their self-adhesive pressure wrap off at the 3 to 5 minute mark, there is a reasonable chance your patient's going to have a bruise. That's what's going to make them sore the next day. Not the needle puncture, it's the bruising that's going to make them feel sore. If instead you tell them to keep that self-adhesive wrap on for 15 or 30 minutes to continue holding pressure, you reduce their risk of having a bruise the next day, and you're going to have more satisfied patients. Once you're done labeling your tubes with the pre-printed labels, you're going to write the date, the time, your initials, and any other pertinent information on the label immediately prior to or immediately after you attach the label to the tube. You're going to label that tube in front of your patient, and you will never label the tube before you draw someone's blood. You do not label the tube before you draw their blood. The person needs to see that their blood has their label on it so that they know with certainty their name is attached to their sample and that the results they receive belong to them. If you don't have a pre-printed label, you will have to hand print the required information on the tube yourself or on a blank label with permanent ink. You're not going to do this in pencil. It has to be permanent ink. Typically, the only authorized colors will be black or blue. No other ink colors will be allowed. Your label, at a minimum, will include your patient's first and last name, their identification number and date of birth, the date and time you drew the blood, your initials as the phlebotomist, and if there's any additional required information, such as if they were fasting. If you have any special handling procedures, which we'll go over in the next section, you'll also have to follow those. That may be protecting it from light, immediately putting your tube into an ice bath. It may be that this kind of test sample cannot wait to be delivered and must immediately be rushed to the lab. It depends on what you're drawing. The last step after you do that is you're going to check their arm to make sure that nothing seems out of sorts. And if it does, you're going to get your supervisor. And as long as everything looks good and the bleeding's done, you're going to apply a bandage. You can use an adhesive Band-Aid. I personally prefer not to use those because they're not going to hold pressure. You can use tape and folded gauze. That also isn't very good at holding pressure. It'll stop the bleeding, but it's not going to hold pressure to prevent a bruise. Or folded gauze and a self-adhesive wrap, which in my experience of the thousands of times I have performed this procedure is the most effective. And you can use any of those to stop the bleeding on the site. If your patient is on anticoagulant therapy, oftentimes you're going to have them maintain a self-adhesive wrap with pressure for a minimum of 4 hours. If it's a person who's on Coumadin or warfarin, they're taking anticoagulant medications, you need to make sure that you directly state to them to keep that wrap on for at least 4 hours. You should also instruct your patients not to carry or lift any heavy objects with that arm for a minimum of 1 hour so the blood clot that forms to stop the bleeding does not get dislodged and destroyed. Once you're done, dispose of any contaminated materials in the biohazard container and other disposable items in the regular trash. Typically, gauze is only going to be considered biohazard if it's dripping wet with blood. And what I mean by that is if I squeeze it and drips of blood come out, it's biohazard. If I squeeze it and it doesn't drip blood, it's regular trash. Your last step is to thank your patient, remove your gloves, and sanitize your hands. It's the courteous way to release your patient to continue on with their day. You're going to remove your gloves using aseptic technique, as was described previously, and you're going to sanitize your hands before you leave the area to continue on with your next set of work, whether that's to draw another patient's blood, or to deliver the samples somewhere, or to go do something else. Considerations to keep in mind: potential complications. If your person's allergic to bandaging materials or your antiseptics or latex, you want to find an alternative supply of equipment that you can use to assist them with this process. Avoid using anything that your patient is allergic to. Worst case scenario, your patient goes into anaphylactic shock and they're being rushed to the emergency room if you use something they have an allergy to. Best case scenario would be mild itching and irritation. But realistically, that's not a best case scenario because it could have been avoided entirely by you asking if they have any allergies and then not using equipment they're allergic to, which is why, because this is under your control, you will never knowingly use equipment that somebody is allergic to. Your patients may experience excessive bleeding if they're taking aspirin or anticoagulant therapy. You have to make sure that pressure is maintained over that site until the bleeding stops. If they bleed for more than 5 minutes, it shouldn't take more than 5 minutes for somebody to stop bleeding when you're applying pressure to the wound. Let your supervisor know. We already went over fainting in depth. I'm going to remind you one more time. Fainting, also known as syncope, is fairly common for people to do when they're getting their blood drawn. It may even be 1 in 100 people whose blood you draw could pass out. And if you're working in a busy clinic, you might have somebody faint every other day because you might draw 50 people's blood in a day. If they've got a history of fainting, just preemptively use a bed instead of a chair and have them lie down. If somebody gently passes out while they're lying down, it's like they took a nap while they get their blood drawn. If somebody's sitting up, now you have to completely discontinue the procedure because it becomes a safety concern. If somebody feels faint before or after your venipuncture procedure, you want to have them lie down until they're fully recovered. It's common to ask your patient how they're doing during the blood draw. Watch for any signs of fainting and prepare to protect them from falling. Your steps to follow in this circumstance. Make sure that the tourniquet's not on. You should release the tourniquet as soon as you establish blood flow, but you want to release the tourniquet if you still haven't done that yet. Because if you don't, and you pull the needle out of their arm, they're going to bleed fairly heavily because the tourniquet will increase the bleeding, and you're going to remove and discard the needle as quickly and safely as possible. Apply pressure to the site and have your patient lower their head and breathe deeply. Ask permission and explain what you're doing if necessary, if you have to loosen their collar or tie so that they can breathe better, and apply a cold compress to their forehead or the back of their neck. Do not leave that patient. You are going to have either yourself or someone else stay with that patient until they recover. And if they don't recover within about a minute to 2 minutes, call for additional first aid responders. Typically, fainting is not an emergency. It's something that is going to resolve itself. However, it could develop into something that is more serious, so you need to be aware of that. And then if your patient passes out, you're going to document the incident. A small amount of pain, speaking of pain, a small amount is normal with venipuncture. You are literally stabbing someone for the benefit of their health. A serious amount of pain, though, extreme pain, a numbness sensation, burning, or an electrical shock sense, or if they feel pain radiating up or down from the insertion site, could indicate nerve involvement, meaning you just stabbed somebody's nerve. That is a worst case scenario right there. It's going to require that you immediately remove the needle, and you're going to let their physician know, let your supervisor know, and document the incident. There is no perfect way to make sure that you never, ever, ever, no matter what, hit a nerve. Everybody's biology is unique, and for all you know, their nerve could be directly adjacent to the vein. But you want to do everything you can to avoid that possibility. Petechiae are tiny little non-raised red, purple, or brownish spots on the skin where you've applied a tourniquet. These are caused by weaknesses or defects in the capillary walls or platelets. And if you see them forming near the tourniquet, it can be an indication that your patient's going to bleed heavily or for a long period of time after you're done with the procedure and you withdraw the needle. It can indicate that the vessels and veins are weak, or that they have some type of platelet abnormality or an infectious disease, or that they're taking anticoagulant medications. If your patient seizes or convulses, you will immediately discontinue that draw. You're not even so worried about the tourniquet anymore. Your number one priority is you are going to get the needle away from the person that is seizing. They are at serious risk of injury if they seize up and start convulsing when there's a needle in their arm. At that point, it goes from being a safe procedure to something that is dangerous. You have to remove the needle from that scene. You're going to hold pressure over the site without restricting their movement. You will loudly call for help and ease that person down to the floor, turn them to one side, and keep their airway clear. Don't stick any fingers in their mouth. Do not do that, because they could bite your fingers off. And then you're down a finger and they're choking on your finger. And that's a lose-lose for both of you. Protect your patient from self-injury without completely restricting movement. You want to move them away from the metal structure. Phlebotomy chairs are often metal chairs. Move them away from the metal frame of that chair so they don't flail their arm out or their head and hit the chair or strike a hard object and injure themselves. And you want to time the seizure and notify first aid personnel. Again, phlebotomy is typically a routine and very safe procedure that is even performed on young children, the elderly, healthy people, immunocompromised people. It's often performed hundreds of times a day in any given hospital or facility. But when one of those circumstances arises, where it changes from being a routine procedure to something that needs to be responded to, do not be shy about asking for help. To ensure that you get the help you need, if there are people around you that you work with, call to them by name when you request help. Hey, you, I need help. Go get help right now. Don't just yell out, help, help, help. People are more likely to respond immediately and effectively when called upon directly by name.